slide. So today, we're very honored and privileged to have Dr. Byington talk to us about a review of the University of California system COVID response. This is an after action report. I'm pretty excited. Next slide. Just a little bit about Dr. Byington is a professor of pediatrics and infectious diseases here at UCSD and is an emeritus executive vice president for the UC Health, the largest academic health system in the US, 12 hospitals, 6 academic health centers, 20 professional schools, and more than 100,000 employees across California under this EVP role. So really impressive. And thank you for the work during COVID, because I'm sure that that was a crazy job to have at the time. I was just a lowly ID chief, and I also still have traumatic dreams about it. And then, so he was responsible for the UC COVID response and advancing the public service mission of our UC health system. So thank you very much for that. Okay, I think we're going to turn it over to you now.
Great. Well, thank you so much. It's really my pleasure to be here today. And let me just share my screen. Let's see, there we go. And I just have to put this. Okay. Can people see that?
Yeah, that's good.
Okay, great. Well, it's really a pleasure for me to be here today, both as a new faculty member at UC San Diego and a recent member of the Prepare Institute. As you heard Dr. Smith say, I am a pediatric infectious disease specialist, and my entire career has been focused around respiratory pathogens of pandemic potential. And so I consider it just really an amazing, fateful decision to be at the University of California at the onset of the COVID-19 pandemic and to be in the role of the EVP of UC Health. So today I'm going to talk about some of the lessons that we learned from the system-wide COVID-19 response, which I was able to lead. I've called it Connected because as a new leader at UC at the time of the onset of the pandemic, it became very clear to me how connected we all were, one UC location to another across the system and across our communities around the state. And so I think as an infectious disease physician and someone who studied pandemics, the connections that are apparent during a pandemic really are impactful to me in my practice and in the way that I look at the world. So the report, you all are amongst the very first to see it or hear about it, was published yesterday. So just fresh off the presses. And at the bottom of the screen, you see the link to the PDF for the full report. I love poetry. Poetry saved me during COVID-19. So you'll see a couple of poems today, fragments of the poems, but also throughout the report. This report, I can't go through all of it. It's over 90 pages long with the lessons that we've learned. And then it has another 100 pages of an appendix. But I do hope that people will look at it. And my hope is that as we prepare for the next one, which we're constantly doing, that some of these lessons will help us as a system and perhaps help us across the state. So in the report or in the presentation today, I really want to talk about leadership, governance, and what I consider actually now in retrospect quite a unique way of managing this pandemic at the system level. Talk a bit about financial accountability because I have some data that I think might be surprising to people on how much money we did spend at UC. I want to share some of the exceptional outcomes and particularly highlight the role that UC San Diego played in those, and then talk about where there are still gaps or opportunities for the future. I will also be presenting this to the Board of Regents in November, and I hope that there would be some interest on the board of funding those opportunities. Let's see, there we go. So one of the things that I learned as I went around the system when I arrived is that people are often unaware of how large and comprehensive the University of California is. And I point out our students and workforce. We have about 280,000 students. That's probably now up to 300,000. And in 2020, about 230,000 employees. We're the third largest employer in California, which makes us one of the very largest employers in the United States. As a new leader, that's what kept me up at night. More than 500,000 souls, depending on the choices and decisions that we made at UC Health and in the Office of the President. UC Health, as Dr. Smith said, is the largest academic health center in the country. We have 12 hospitals, about 4,000 licensed beds. We take care of patients over 1 million inpatient days each year. 8 million now, it's really closer to 9 million outpatient visits each year. And we're the only public academic health center in California, which means we really have an alignment with the state of California to serve everyone in the state of California. And then finally, we have 20 health professional schools across our system. And we don't have just any health professional schools. We have amongst the best health professional schools in the world. So the talent that was here already within the system that could be leveraged to help in our decision making was immense. So I'll start with leadership, and leadership really matters. We had 2 presidents of the University of California during the public health emergency. Janet Napolitano, who was the former Homeland Security Secretary and a lawyer, and then President Michael Drake, a physician. Both of them brought very important leadership qualities to the office and understood what a pandemic might mean. I'm very, very grateful to President Napolitano, who took my call on January 1st, 2020, New Year's Day, when the campus and the office of the president were closed for the holiday, to hear my concern about a report that I had heard on the radio the day before describing an unknown pneumonia outbreak in Wuhan, China. When I heard that report, I'll never forget where I was. I was packing a suitcase to go from my family's home in Texas for New Year's to go back to return to California. And just the wording of the report and the things that were being said and shared reminded me so much of SARS-1. And I felt like this could be something very important that could evolve into an emergency. And I had a terrible pit in my stomach when I heard that report. So I'm really grateful to President Napolitano that she took my call and that she took the call seriously. And we began to plan in earnest a potential pandemic response on January 8th of 2020. That was our first official meeting when the Office of the President opened following the winter holidays. And then, of course, President Drake, it's been my privilege to work with him. And as a physician, it made my job very easy because there were things that I just didn't have to explain to him. He understood right away why we needed to do something or why the recommendation was what it was. So these two leaders, although were both very different with different backgrounds, had essentially very similar, if not identical, goals. And the first was to protect the health and safety of our patients, students, and employees. And my first charge was our patients and health center employees as EVP of health. But that quickly evolved to the entire system.
Because
What's wrong? Um, maybe there's someone who might want to mute. There we go. Okay.
I mean,
Okay. Um, and so they wanted to ensure that we protected the health and safety of the people of UC, but also to enable our education, health, research, and public service missions to continue as seamlessly as possible. They noted that we needed to maintain financial solvency, and when you see some of the costs involved, you'll see why this was so important. And then, although it was not stated, I think it was really important that they provide leadership for the state and for the nation. The prominence of the University of California nationally, as well as in our state, really meant that people were looking to us from the very beginning, um, looking at the decisions that we were making and trying to uh, emulate those decisions in some times and to fight those decisions in other times. One of the statements that President Drake made that has stayed with me is that what was guiding him was that overreaction was preferable to underreaction, especially early in the pandemic, because small decisions and small changes are amplified so much over time. And he would rather be accused of overreacting than underreacting. So both of them and me as well, we were operating in a period of crisis leadership. Crisis leadership offers us opportunities that you don't have during regular times. When there is a crisis, you have opportunities for alignment, you have opportunities for much more rapid action and even change than you would have during standard operating days. And if you're successful in a crisis, what you learn and what you implement can actually be translated to the daily operations and can change the way you operate if you develop trust, if you can demonstrate the benefit of working collectively, and if you communicate. So I believe we've done those things, and I hope that I will show you some examples as we go through the talk. But let's talk a little bit about governance. The governance of the UC system is very much federated. I'm assuming that all of you are on the University of California, San Diego campus, and you're probably very tuned in to your campus leadership, your campus priorities. But the system is large. And one of the things that was decided very early on was that we couldn't not independently, campus by campus, department by department, division by division, react and respond to the pandemic. It was impacting all of us. The questions were similar across every location. And to have different advice, to have different policies and procedures would have been very ineffective and perhaps costly in lives and costly in dollars and costly in things such as lawsuits, bad morale, and the like. So from the very beginning, it was determined that we needed to find a way to act as a system, to act collectively as a system to support safer clinical learning and working environments. And the concept of people first was very prominent in all of our discussions. These were actions meant to save the lives and the health of people. And our goal was to limit the variation across UC settings. All of the UC settings are quite different. We have some campuses that have very well-developed medical centers and health centers. We have some campuses that do not have that. We have campuses that are big. We have campuses that are small. We have campuses that have strong infrastructure around them in their very well-developed urban environments. And we have some campuses that are more rural and have very little in the way of community resources. In fact, the campuses are expected to deliver those resources. And so, particularly from a regent standpoint, it was not acceptable that a student at UC Merced or a faculty member at UC Riverside would have a different experience or different level of safety compared with someone at UCLA, UCSF, or UC San Diego. UC Health was tasked then to develop evidence-based policies that could be used across the system and then also to help support campuses and other locations to implement what was being recommended. And if you go back in time and think, even on campuses that had strong medical centers, we did not have an infrastructure to do testing in our academic facilities. Think about how much more difficult that would be in a campus that did not have a medical center. So one of the first things that was discussed and developed was the University of California Consensus Standards for Operations of Campus and Agricultural and Natural Resources. This began development in about February of 2020 and was approved in its final form by the Board of Regents May 20 of 2020. And basically it was 10 requirements for all UC campus locations, all UC locations, whether in California, Washington, D.C., Los Alamos National Lab, everyone had to abide by these 10 requirements. That can sound very top-down, heavy-handed, central, authoritarian mandates, but these requirements were written in very broad ways with the hope that we would have radical inclusion of the campus locations and the various locations in how we implement these recommendations. So for example, one recommendation was that all locations had to have testing, and that testing had to be available and return results within 24 hours. But there was a great deal of flexibility on how the campus or location chose to implement that. Some chose to develop their own PCR testing. Some chose a sequencing-based approach. Some used rapid tests. Some outsourced the testing to private entities. Some worked with their health departments. So there was a great deal of flexibility in how individual locations would implement. And in order for that to exist, they had to be part of the team that was making the recommendation. So I'm going to talk about that in just a minute. We really wanted to value local expertise and capacity. And what we saw over time is as we were working together, bringing these experts together, best practices began to develop and were shared widely across the system. From what I have been able to evaluate in the 1918 pandemic, in the 2009 H1N1 pandemic, we had never worked like this before as a system. There had been no evidence in the past of this type or level of collective work with a system-wide policies with radical inclusion and local implementation and design across the campuses. So I do think that this was a unique model and hopefully something that would continue moving forward. This is one statement that was made by President Napolitano that I think really reinforces what we were trying to do. She says, we cannot predict how the situation will evolve or what future measures we may need to take to uphold our mission. What we do know is that we will face the future with courage and we will find our way together. And this statement was made as pretty early in the pandemic in April, as she was trying to reassure the system that there would not be mass layoffs as we were all sheltering in place. But I think that we saw this lived out again and again, that we were going to work together to figure this pandemic out. So one of the ways that we chose to work together was to use the principles of collective impact. Collective impact recognizes a commitment between multiple organizations all working towards the same goal. And when you think about UC San Diego or UCLA or UCSF, each of these are large, complex organizations on their own that are run exceedingly well and that believe and know that they have the capacity to answer the hard questions and to do the hard work on their own campuses. So getting them to agree to a common agenda was perhaps the most important thing that we did. And then finding ways to track metrics together, to participate in mutually reinforcing activities so that we could leverage the expertise. That became really prominent, and I'll show you some examples. There were just clear leaders in the diagnostic space that could contribute to the entire system, in the modeling space, infection prevention, so that each location did not have to reinvent the wheel, but we could find every type of expertise that we needed in the system. Collective impact also means that you have many multiple avenues open for communication, and that a portion, some group, has to provide the backbone of the organization. And I would give a shout out to the Office of the President as being the organization that was the backbone for this collective effort. And there were many, many Office of the President staff who were, this was their only job as we moved through the public health emergency. So this is what the organization looked like. Prior to the pandemic, the UC president reports to the chancellor, the chancellors report to the UC president. They all report up to the regents and to the governor of California. And in the time of an emergency, UC has something called the Management Response Team. That MRT was very effective and had been used multiple times for things like earthquakes or wildfires. But these were events that were very short-lived and usually impacted only a single location at a time. An earthquake, might impact one or maybe two schools. The wildfires may have been present in Southern California or Northern California, but they were not prepared for a pandemic that would extend over years. The other issue with the MRT was that it had no representation from health. Even though UC Health was over half of the organization, and that the most likely scenario that would involve the need for system-wide response was a pandemic, there was no health representation. So we actually had to create a new mechanism, which we called the UC Health Coordinating Committee, and that became a subcommittee of the MRT. And so underneath, and I had the privilege of chairing that committee. And so underneath that committee, we developed subject matter expert working groups. We made connections across procurement, operations, government, outreach, existing system-wide groups that were already in place, like finance, student health, and we would tackle big questions, deliberate, make a decision, pass that up to the MRT, and then it would be taken back to the president and the chancellors for final decisions. Again, that was not a way that we had worked in the past, and now the UC Health Coordinating Committee is a permanent committee within the management response team. During COVID-19, we had several subject matter expert groups. We started with public health and infection prevention and laboratory, and then we ended up expanding as new questions came up with an education group, a telehealth group, bioethics group, clinical research group, and we also had metagenomics and sequencing group, and finally a long COVID group. Not all of them are shown on here, but those groups, one of our rules was that there had to be representation from every campus on each group. It made it somewhat challenging because some of these groups had over 100 participants, but the involvement of each campus in the decision-making actually made the implementation much easier and developed trust across the system. Here are just some pictures, I can't name everyone, of people who led groups, who participated day in and day out. I was talking with them on my phones, by Zoom, having meetings, and they contributed their time without extra compensation for 2.5 years, and they are really heroes across UC. These groups were responsible for determining the practices that we were recommending and policies across the UC system. Everything from simple guidance around protecting people from viral transmission in the work or school setting, to big controversial policies such as our vaccine policy, and everything in between. This little timeline shows some of the questions we tackled during phase 1 and phase 2, and then of course there were other phases as we move forward. But just capturing the timeline tells you how acutely we were having to answer some of these very large questions. And just to put in perspective for the infectious disease people here, we began to talk about a vaccine mandate in February of 2020, not knowing when a vaccine would come, but knowing that if it did come, UC would be on the front lines of recommending that vaccine for everyone. These policies that were developed, recommendations, guidance, were implemented across our hospitals. They were implemented across our academic settings, and I'll just spend a brief amount of time here. The laboratory testing, diagnostic testing, both in clinical laboratories and surveillance testing, were huge, huge endeavors that took a great deal of advocacy at both the state and national level. It was the diagnosis of the first community transmission of COVID at UC Davis on February 26th that resulted in a change allowing clinical labs to perform diagnostic testing on February 29th. We had been advocating strongly at the CDC and the FDA in January and February and weren't getting anywhere. But then the diagnosis of that first patient with truly community spread changed everything. We had to advocate in multiple ways to allow testing to take place on our campus locations, and to provide free testing was a huge benefit for those who were associated with UC campuses. And I'll just point out the bottom row here to really highlight where UC San Diego made dramatic contributions. The first was wastewater testing. I brought forward the possibility of wastewater testing in April of 2020 to the Council of Chancellors, and it was Chancellor Khosla who was the only chancellor who grabbed onto that idea as a potential mechanism to keep campuses open. and invested a lot in creating the wastewater sampling that you had on the UC San Diego campus. And that knowledge then spread to all of our campuses. I point out Natasha Martin, who developed the models, the modeling that we needed to decide how many students can be in a dorm room. How should we handle masking on campuses? Where should people be masked? In classrooms, in cafeterias, etc. Her modeling and her modeling group informed the decisions across the system on campuses that did not have the expertise that UC San Diego did. And then finally, on vaccination, UC San Diego created the first vaccination superstation in the state. That superstation was copied through Major League Baseball across the country, and also copied throughout our organization to allow us to deliver vaccination rapidly. And for example, we made a goal of vaccinating all 100,000 frontline healthcare workers in 4 weeks, and we accomplished that, partially because of the planning and the group knowledge that we had across the system. The knowledge of these subject matter experts also helped inform state policy. So we were meeting with these subject matter experts all the time, and many of them also served state-based roles. And I think especially this graph has stayed with me post-pandemic of the difference the UC subject matter experts made to the first wave of the pandemic in our state. We were predicted to have a very, very devastating first wave. And you can see here from the New York Times COVID tracker, the comparison of California in April of 2020 to Louisiana, New Jersey, and New York, and cases per 100,000. I believe part of the reason that we fared so well was the recommendation for early shelter in place, with California really leading the nation on that decision, and for the availability of and recommendations around non-pharmaceutical interventions. We had so much excess capacity within UC Health in March and April of 2020 that we sent our healthcare providers to New York to support them, and to the Navajo Nation and across the border in Mexico. But all of this cost a great deal. And one of the things that I think people do not realize, and without this report, we might not have all of the data, the university experienced losses or new costs that totaled more than $3.5 billion. Let that sink in for just a moment, that the organization that you work for was willing to invest $3.5 billion to protect our people and to protect our assets. About 1.2 billion of this was in the health centers, and 2.3 billion was across the 10 campus locations. Let's see. One of the areas where we really invested was the addition of emergency paid sick leave. This is one of the things that I think really demonstrates that we were all in this together. We already had paid time off as employees of the University of California, but the system added so much emergency paid sick leave during the COVID pandemic. And over the 3-year period of time from 2020 through 2022, our employees used 12.5 million hours of emergency paid sick leave, and this was valued at approximately $500 million to the UC system. This was one of the larger expenses that we had. Testing was another. And when we look at the federal relief that came in, federal or even some state relief that came in, combined across health and the academic side of the house, we recovered about $1.69 billion which represented about 50% of the financial losses we experienced during the public health emergency. But I think it's important to see that there was a wide variation in the recovery of loss. Health centers were much more easily able to recover their losses and recovered about 82% of losses, compared with the academic campuses, which recovered only about 30% of their losses. I think this is really important information for those who will deal with pandemics in the future. So that's a lot of money. And what did we get for our investment? Was there a return on our investment? Did we meet our goals? So if you remember, our first goal was to protect the people at UC. And one of the things that I'm engaged in right now is original research around excess mortality in the UC employed population. These are preliminary. We're not finished with the analysis, but I think this is going to be very close. And so this is looking at the annualized mortality rate per 100,000 people of UC employees in red and working Californians in blue. We're looking only at the 18 to 64, which we call working age population. The solid lines that you see are what we would expect based on the baseline of year 2018 and 2019. And this is what you would expect in the solid blue line and in the solid red line. And around it, whatever is above is the excess mortality. Even before we went into the pandemic, if you were employed at UC, you did better than the general California employee. There were disparities between UC employees and California general employees. And those disparities are perhaps greater than can be accounted for by things such as socioeconomic status. 78% of UC employees are in pay bands 1 and 2. Those are the lower pay bands in the UC system. Pay band 1 means you make less than $54,000 a year, and 36% of our employees are in that pay band. And pay band 2 means you make more than $54,000 but less than $107,000, and another 42% of our employees are in those pay bands. So I think that there is this idea that UC employees are all wealthy, and therefore that's why they do well. That's not true. Our average pay is very similar to California's averages. But there are other things within our workplace that make it a safer workplace, and perhaps helps to prolong the lives of the people who are associated with UC. So you can see there was a difference before the pandemic, but the discrepancy widened dramatically during the pandemic, whereas UC kept their excess mortality very, very low, and we believe that number is 17 per 100,000 employees. We saw a much wider, a widening of excess mortality across California. And when we look at all employees, including those who are older than 65, we see a further widening of the disparity. And you'll see that the y-axis is different on this graph. The first graph went to 600 per 100,000. This graph goes to 2,000 per 100,000 when you include working Californians older than age 65. And I think it offers a real opportunity for us to begin to discuss the importance of workplace and workplace policies to the overall health in the United States, given that we don't have universal health care. Where you work really matters, and why you work over the age of 65 also really matters. And I think there's probably a big difference between working out of necessity over the age of 65 and working out of preference over the age of 65. We also experienced great outcomes in patient mortality. no one knew how to treat COVID-19 when it first came. And we did a lot of things as a health system to share knowledge and gather knowledge. Early in the pandemic, we met with colleagues in China and colleagues in Italy to understand what was happening and to be better prepared. We also knew that we were going to have to share data. And so we began to work on those things in January, February, March. And I think that we experienced excellent mortality because of the sharing of the expertise across the system. And in 2023, all UC academic health centers were recognized in the top 10 for the lowest severity adjusted mortality in the United States during the COVID pandemic. You can see the rankings here for Irvine, San Diego, San Francisco, Los Angeles, and Davis. To have all of ours in the top 10 and half of the top 10 was the UC system. If you had to be hospitalized for COVID-19, it made a difference where you were hospitalized, and being hospitalized at UC gave you the best possible chance of survival. Here are all of our CEOs and medical center leaders being recognized at Vizient, which is the organization that measures quality in academic health centers. And again, we were in the top 10 of over 107 academic health centers that were evaluated. Part of the reason that we could do well is because we shared our data. So this was easier said than done. All of our campuses, our health campuses are on Epic, but all of them used different instances of Epic. And so the sharing and combining of data was not perfect at the onset of the pandemic. And in fact, we would combine data on a few things once a month. I knew there was no way we could get through the pandemic like this, and we began to urgently work on being able to update and consolidate data every 24 hours. This is our consolidated report of inpatients for all of the system for the entire public health emergency. We had reports like this for every ventilator, every ICU bed, all of our pieces of PPE, all of our nursing staff. We were able to share this information and to actually move resources across the system when we needed to ensure that we never entered crisis standards of care. And then that brings me to this. This is one of the enduring resources from our system-wide response. And this is the report that was published in April of 2020 on allocation of scarce critical resources under crisis standards of care. As a new EVP, it was shocking to me that we did not have this for our system. It was never written during the H1N1 pandemic, and we were very lucky that we didn't have to implement crisis standards of care during the H1N1 pandemic. But we now have a lasting document that is appended as the appendix of this report, and there for individuals to use in the future at any of our institutions on the not only the how you would allocate, but the equitable allocation under crisis standards of care. This bioethics group worked under intense time pressure, but always kept a health equity lens. And this guidance came out before the state of California guidance. We did not have guidance from the state as we were trying to prepare. And when the state of California's guidance came out, it was immediately criticized for being biased against the elderly, biased against those who were disabled. And they had to pull their guidance back. And they came to us to ask if they could use our guidance to inform the state's guidance. So our subject matter experts were of such quality that any state or national committee would be glad to have these individuals assist and advise them. We also were able to maintain the education enterprise. And this is one publication talking about the safe reopening of college campuses during the COVID-19 pandemic. When we did return in fall of 2020, we never once had to close any campus for a large outbreak, and there was no evidence that our campuses were being super spreaders within our communities. That was particularly important for the rural campuses that didn't have um, excellent health systems surrounding them, because many college campuses became super spreading events to their rural communities, resulting in excess hospitalizations that could not be cared for and excess mortality in nursing homes in their surrounding communities. We did not experience that. We also saw an increase in research productivity during the pandemic. UC investigators are oops, I need to go back. UC investigators, I don't know how to go back. There we go. UC investigators are people that I never worry about. There is not a grant that UC cannot compete for in a very successful way, and there are phenomenal investigators across the system. When you take our system together, we are the most funded system in the United States and then in the world. Our investigators were quickly able to redirect their academic capacity and their research resources to begin to answer urgent questions that the pandemic posed, and they were very much able to successfully compete for grants. The NIH analyzed all of the COVID funding, research funding that was made available in the United States, and it was a little more than $5 billion. 5 institutions in the United States received half of that money, $2.4 billion, and UCLA was amongst those 5, primarily for the funding that they got for their trial network for COVID drugs. But when you look at each campus and their research productivity and compare 2019 to 2023, you see a remarkable increase in the amount of dollars funded through the NIH and also impressive increases in the NIH rankings. It's hard to move up even one spot on NIH rankings, and we saw consistently increased dollars and increased NIH rankings. Overall, as a system, we increased our NIH funding by 25%. I think that's also very important for people as they think about the next pandemic. And I would say you don't have to worry about UC researchers succeeding. They will find a way to succeed. Here are some of the grants that are responsible for this large increase, because these grants represent literally hundreds of millions of new dollars in the system, and they're focused on pandemic preparedness. So you see across, of course, you have the Prepare Institute, but we also have a new CDC network for pandemic preparedness at UC San Diego. UC San Diego got a RADx award from NIH for diagnostics, so did UCLA. NSF made new centers for pandemic insights, and of course, UC is included. And one of the things that I like about that is that this one actually is a partnership between Davis, UCLA, and UC San Diego. So we also learned how important it is to work together across the system, and that we can compete for even bigger grants when we work together. I think this represents an opportunity, and I know there are more grants. The Prevent Network that Louise Laurent just got funded from CDC, it's another $28 million award over 5 years, is not listed on this, and there are probably others across the system. And one thing that I see is an opportunity for us to coordinate these centers in some way, at least to allow us to share study protocols, share data, inform each other on what we are doing. And then finally, we began to work in a different way with the state of California. Both UC and the state developed new capacities. The state awarded $160 million to various entities across UC during the pandemic, but they were awarded in a non-integrated and non-strategic fashion that really just depended on who knew who and pre-existing relationships. For example, genomic sequencing, there were millions of dollars given for genomic sequencing to multiple different investigators across the UC system and absolutely no coordination between them. So there were real opportunities to redirect and to plan. So I was the principal investigator for 2 years on a planning grant to find ways to strengthen our health security partnership between California Department of Public Health and UC. And so today we are at this point where I think we really need to move beyond a crisis mindset to an opportunity mindset. We deal with public health, we deal with preparedness in kind of a feast or famine way where funding goes. If we're in the middle of a crisis, we just throw money at it. But then there's no planning or infrastructure or strategy for how we keep the wins and lessons that we've learned so that we start at a higher and higher place for the next one. So there were many opportunities that I point out in the report, but I just want to focus on 3 for the UC system. The first is data integration. So much of the data that you see in the report was manually collected. We should not be manually collecting data across a system as prominent and predominant and important as the UC system. And so between emergencies, we should be investing in real resources that allow us to have a more integrated data process and allow us to have a more unified view um, of our people as we move through a crisis, but also as our people as we move through our normal business operations. I have made a recommendation that we have a new position at UC, a system-wide position that we call a Chief Health Security Officer. I essentially serve that role as EVP for Health, but I cannot stress enough that I do not believe that it is the role of the EVP for Health. I happen to be an EVP for Health who was an infectious disease physician with expertise in pandemic preparedness. That is not in the job description of the EVP for Health. And we could have an orthopedic surgeon or a nurse or any number of people in that role. And I think that this Chief Health Security Officer is a full-time role that can work broadly across the system to maintain relationships, to maintain preparations between emergencies, and then when an emergency would arise, would take on the leadership of the Health Coordinating Committee and perhaps even the MRT. And then finally, through the CDPH UC Government Academic Partnership, we have developed a charter and an executive committee that is still meeting. We have developed joint areas of focus, including preparation, laboratory, data sharing, communications, research, and workforce development. And then there are areas where UC can particularly contribute, including our medical expertise. Many of the protocols that the state developed around ventilators depended on UC expert input, the vaccine evaluations, etc. We have those experts in our system. We have health data within our system through the enterprise data warehouse, and obviously we have research prowess. And so my goal in writing this report was to leave something for the future. And this is a poem that was very meaningful to me both during the pandemic and then as I was writing the report. Um, and I think this kind of preparation is an attempt to leave something of sweetness and substance in the mouth of the world. Happy to answer any questions. Thank you.
That was great. Thank you for that. Just one quick clarifying question on the network at UCLA. I happen to be the protocol chair for that group, even though the money was through the UCLA group on the AIDS clinical trial.
The
group.
active network?
Yeah, I was active too. So that was that group. And they're now trying to figure out if they want to continue to do sort of pandemic response. And I think they should, of course. I mean, I was the one that introduced them to COVID and then to Mpox. But I do think it might be good for us in leadership to say this is something that UC wants to be a leader in, because I think they're having some internal, they want to get back to the HIV work, which I think is great, but at the same time, they have know-how to be able to handle these infectious diseases.
I mean, this is exactly where everyone is. They have this know-how that we don't want to lose. There's wastewater surveillance know-how that we don't want to lose, genomic sequencing that we don't, modeling. There's so many things that we can't afford to lose. I was just yesterday and the day before at the National Academy. National Academies had a workshop on H5N1 research priorities. And a clinical trials network was one of the #1 priorities that was being proposed, not specifically for H5N1, but that we should just have it all the time so that it's ready to go. And I think UC would be a remarkable place to house that type of a network.
So that's good that you brought that up. I actually talked to the NIH with the AIDS clinical trial group with Judy Currier from UCLA and pitched the H5N1 trial to the NIH. And it's the same thing that happened during COVID, to be honest. I pitched to them in February of 2020 a trial, and they all said no. In fact, Tony Fauci's like, it's never going to come to the US. I'm like, oh yeah, it's coming. So
it's
sometimes
coming,
it just takes time. Yeah. But I do think
we have to persevere. We have to keep persevering, because the same things that I'm seeing in California, the national leaders are seeing the same.
Yeah.
And when you have FDA leadership and National Academy leadership and CDC leadership, I mean, Tim Uecke at CDC is major, I would say the predominant influenza researcher in the United States. This is his #1 research goal. That's a strong voice. And California is right in the middle of this epizootic with H5N1. I mean, I feel like I'm watching the slow train to disaster.
Me too. Like we've been working really hard to make sure that our BSL-3 is ready. And that's been, we're just counting pennies to try to get it together. But yes, I think we need to have that sort of forward-looking. Another pandemic will come.
Another pandemic is coming sooner rather than later. And, having the BSL-3 ready at Davis was super important as we were developing testing for COVID. And, we had to have a place, and FDA and CDC, they were not helping us,
Yeah, no, they were actually hard. I got a very nice little letter from the CDC telling me to stop testing for COVID because it wasn't their device. I'm like, let me know when that works.
I try not to talk too much about that early time because I'm certain we were breaking some laws, but I mean, it had to be done. It had to be done. So anyway, yeah.
Anyway, I've hogged your time. So does anybody else have any other questions? Well, thank you. This has been great. I love that you put this together. Oh, I did have one other question. So right now in the CTSAs, the all UC braid system, the NCATS wants us to keep contributing data for their NCCC, in 3C. And, I might come back and talk to you about that because there's a lot of hurdles when we're not in the setting of a major pandemic to be able to still do those sorts of data
It
sharing.
was hard even when we were in the pandemic. Yeah, but no, I'd be happy to talk to you. And I think that, yes, CTSAs are another potential um, stakeholder to push. You know, the
Mhm.
nation, it may not be until we get a pandemic like H5N1 that does kill a lot of people
Yeah.
that they're ready to invest. But I just feel like we have to keep advocating. And my biggest push is to advocate to the regents right now and hope that, you know, we'll get this on their radar.
That's what I do. Just talk to anybody. And we have a clinical, luckily we have the protocol ready for a clinical trial for H5N1. So like, do we use Tamiflu? What else? You know, there's other drugs out
Yes,
there.
there's other drugs. Yeah,
Yeah.
yeah. And if you don't know Tim Uecke, um, I think there are ways that I could make that connection. But I believe he would be a very strong advocate. And if we at UC could put something forward that's kind of, you know, halfway there, we could get some support. It is literally his number one goal.
Yeah, let's do it. So just if you make a connection, I have it ready. We can give him my dog and pony show. So it'd be great.
Okay, all right. Well, I didn't get to see anybody
Thank you.
else's faces, which I sort of was hoping for, but anyway, thank you for those who showed up. I appreciate it.
And it'll be, we have a lot of audience who watch this after it's been recorded. So I think we hit 100 not too long ago. So, but the next seminar is November 26th. It's going to be on breast milk infectious disease tests with Sandra Leibel. It's going to be great. We were definitely in the lead of doing the breast milk testing for COVID, but also for Mpox. The big milk group, the Mommy Core, is just amazing. So I'm really excited to have that seminar in November. Okay. Thanks, everybody.
Take care. Bye-bye.